And with that, I'd like to turn things over to Juli.
Well, thank you, everyone. I appreciate you making time in the middle of summer for a webinar, and we're excited to be with you today. My background is in reimbursement, and particularly in emergency medicine, urgent care, and telehealth. And what that has done has meant that over my 25-year career, I have bumped into your enrollees. I have bumped into the people that you serve. I'm sure it's not lost on you that emergency medicine provides the bulk of care for the uninsured in America today. And we provide a great deal of care for those who are served by Medicaid and CHIP for a variety of reasons associated with those who are most vulnerable. At Zoll, we serve providers, large IDNs, payers, as well as states in their efforts to come alongside patients with data, software, and life-saving medical equipment that really makes a difference when patients need it most. So with that, let's talk a little bit about what we want to focus on today. As we look at the PHE, and in particular, the unwinding of the PHE, our goal for today is to look at how the continuous enrollment requirement has impacted Medicaid and enrollees, to look at loss and churn, and to see how the ending of the PHE will be impacted. I believe by looking at the data and the trends, we can gain some insights as well as some best practices for how we can move forward together. So I don't know about you, but the announcement of the unwinding and the date of the ending of the PHE has been something that's kept me up a little bit at night. There are a number of forces coming together in healthcare over the next 12 to 18 months. I believe it's going to be a very pivotal time for providers, payers, and patients. But what I'd love to hear from you is, as you consider the unwinding of the PHE, what, if anything, is keeping you up at night? Do you have concerns about your state partners and their ability to successfully navigate the unwinding and the redetermination process? Are you concerned about downstream health consequences for what we see in our vulnerable populations when the uninsured grows? Are you concerned with the fiscal impact upon your own organization? Or are you most concerned with eligible individuals becoming disenrolled just due to procedural or administrative burden reasons? So if you take a moment and fill that out, that would be wonderful.
All right, we got some answers coming in. Wonderful.
Great.
Still have time, folks. Love to get your opinion.
I know this has been a topic top of mind for many of us for some time. So curious what aspects of it are most concerning to you.
Okay, last chance, and I'll go ahead and share.
All right, we're fairly split, all of these being key concerns, but it looks like the most significant is eligible individuals losing their Medicaid status, as well as just concerns over how the states can navigate through this and what will the downstream consequences be. That makes great sense to me. And I realize too, there are consequences for our own organizations, both the cost to walk through this and the future costs. And I think if you're at all like me, Utah really elevated our concerns. It's interesting that one of their slogans is life elevated. By the way, just a small point, I actually grew up in Utah. I love Utah. But I was very concerned when I learned about the fact that 41% of the CHIP enrollees in Utah became unenrolled. They couldn't locate them, and we don't know. Did they go to other insurance? Did they go to the ACA? Did their parents find a better financial situation? Or have they simply lost coverage? And I think it's top of mind for all of us, that concern that this could happen broadly across the country. In a recent story put together by Georgetown in their study, actually, they put this graphic forth. They said 37.3 million children are at risk. Not sure that's exactly true. I think the number's far lower than that. But the points of their consideration, I think, are valid. That being that some people are still eligible and should still be enrolled. Others are no longer eligible. And how do we help them with their gaps? As we look at that, how do we transition to other sources of coverage, CHIP, the ACA? And when we look at that, what are the barriers? The premiums, the fact that they can't afford the coverage, the family glitch, the 60-day requirement when we look at the marketplace, and then just the overall lack of affordability. These are all potential concerns as we look at how do we best come alongside our enrollees. I love this cartoon. I think it's wonderful. A lot of times there are unintended consequences to our policies. And certainly in the middle of the pandemic, this policy was a very good one. But there are some unintended consequences, and we're about to live through those. In some cases, the state's not walking through their revalidation processes for some time. There are a number of unintended consequences to a good policy often, and how can we mitigate that? And how can we do it within an industry, within a sector of policy and government that quite honestly has a lot of administrative burden? There's a lot of requirement, there are a lot of steps. Can we use text? Can we use phone? Can we only use snail mail? What does the state require a enrollee to do to be redetermined? And is it reasonable? Does the state have the staffing to walk through this process? The risks are significant, and therefore the chatter seems valid. The Washington Post, I'm sure many of you saw this, published in March, that millions of vulnerable Americans are likely to fall off Medicaid once the federal public health emergency ends. One of the individuals who was quoted in the article said, "The main concern I have is people are going to be cut off for reasons that have nothing to do with their eligibility." And I think that's a very significant concern. Gordon Bonnyman, an attorney with the Tennessee Justice Center, a nonprofit working for affordable health care, said, either they drop the ball or the states drop the ball. And I think that's very fair. There is an onus on the state associations, there is an onus on the MCOs, but there's also an onus on the individual families, the enrollee, and this is not their strength. And I think we have to recognize that as we look for ways to partner alongside them. So as we look at what the data tells us, what we've seen, according to the Kaiser Family Foundation, is that prior to the pandemic, we were experiencing a baseline growth in enrollment of approximately 4%. In addition to that, we saw a 22.2 million increase in enrollment projected to the end of 22. I think very few of us think that the PHE will expire before the end of 22. And so when we look at the baseline of 3.5 million and the continuous enrollment growth, we see a total of 22.2 million in enrollment growth during the pandemic. And that's made up of some interesting cohorts. First of all, we saw an increase in baseline enrollment in the aged and the aged with disabilities. And if we think about trends within our population, that makes sense, as we've seen so many people transition to retirement as baby boomers. We saw substantial growth in other adults and ACA expansion adults. That too makes sense. We had a number of economic conditions at play. We also had 5 states that moved forward with expansion during the pandemic period: Idaho, Missouri, Nebraska, Oklahoma, and Utah. And so it makes sense that we saw such growth in adults, even though that might be a little surprising at first glance. But we also saw growth of 42% in our pediatric population. In fact, adults outpaced children. That was a little bit of a surprise. But when we put those two cohorts together, those of the ACA expansion, non-expansion, and the economic factors, I do think it makes sense to those of us who are close to the numbers. So here again, you just have that visual of baseline enrollment growth, folks like those aged and disabled becoming a greater portion of the population compared to those who really are that continuous enrollment growth. Georgetown University Health Policy Institute took a deep dive look at children and Medicaid. The title of their study, Millions of Children May Lose Medicaid, What Can Be Done to Help Prevent Them from Becoming Insured? And there's some insights here that we can glean. One of the things they talk about is they really see two ways that children could lose coverage. The first being that they get lost in the transition. In other words, they're still eligible, but for a procedural reason or an administrative burden, they don't make it through the redetermination process. And then the other way is that there's some change in their financial situation, but that does not make sense to, or doesn't equally transition to that they receive care or insurance in another source. Because simply because there's been a financial transition in their guardians, that does not necessarily always translate to better coverage for the actual child. So how can we dive down into forecasting what's going to happen with our pediatric populations post the end of the PHE during the unwinding phase? Well, Georgetown thought, let's look at what happened previous to the pandemic. Let's look at disenrollment in 2018. And what they found was that about 18% of non-disabled children were disenrolled in 2018. And they felt that of that 18%, 44% of the children who were re-enrolled in a year, and they re-enrolled again. And so there was a period of time where they were unenrolled, but then came back and re-enrolled, which would tell us likely they were still eligible during that time frame. And when we look at that, it gives us a way to estimate our own pro forma of our own pediatric population within our enrollees. So if 18% of children were disenrolled, and of those, 44% came back within 12 months, we can estimate that they were likely still eligible. So if we just look at the 2018 numbers and we apply those rough percentages, what we see is rather than the full cohort of the 18% that was disenrolled, it's only a portion of them who truly were no longer eligible. And that comes down to the 3.8 million in 2018. So you could take these percentages, you could apply it to your own population, your own enrollees, and get an estimate of what your pediatric churn is likely to be during the unwinding of the PHE. So when we talk about those kiddos who truly are no longer eligible, what are some of the things that we want to be aware of and that perhaps we can help in the transition? Well, one of the things we want to be aware of is this marketplace window. And when we talk about things that keep me up at night, it's things like this related to the unwinding of the PHE. Because when I talk about a vulnerable population, they're not great with deadlines. They're not Johnny on the spot in understanding regulations. So they may very well have had an economic change. That means now they're not eligible for Medicaid or CHIP, but they are eligible for some support through the marketplace. But they only have 60 days post that transition to make the change. So how can we as MCOs and state agencies be sure they're aware of that? How can we identify that cohort and be sure they receive the support that they need? In the Georgetown study, they talked about some options, some strategies to reduce procedural disenrollments, which I think is kind of where we need to focus. What are the things we can avoid and help those folks who should still be enrolled to stay enrolled? They talked about improving automatic renewal rates. They talked about boosting eligibility and call center workforce capacity in the state agencies. They talked about increasing funding for community-based outreach. Talked about sending follow-up notices and reminders when action is required. Of course, we know part of the struggle is, do we have the right contact information? Maximizing use of communication modes, whether that be phone, text, automated messages. Expanding the ways enrollees can interact with the agencies, I think is really important. and working with the MCOs and healthcare providers to update contact information to remind members that their renewal is due, and then ensuring that call centers have adequate staff and that they have some scripts to work from. Inside these pieces of advice, there are some automation tools out there in the marketplace that we're going to talk about towards the end of the presentation, where we can look at getting some automation and some help around this. And I think that's really important. If we contrast what some of the states are or are not doing, one of the big struggles is antiquated systems. And for example, in this recent article, Florida was brought to note. And they talked about the fact, Jody Ray, a director of the Florida Covering Kids and Families Association, she's been sending emails since the fall. She's been reaching out saying, I'm here to help. She hasn't heard anything back at the time of this publication. And unfortunately, Florida is in a situation where their own eligibility system, their own databases are fairly antiquated. And that really is going to create a challenge. I imagine that some of you have reached out just like Jody. You've offered help to the states with whom you partner. And so I'd love to learn a little bit about how that went. So our next poll, in attempting to work alongside our state partners, here's what we've experienced. Option A, they're open to our assistance. Option B, they've asked for specific help reaching out to enrollees regarding the redetermination process. C, they've even asked for our help with social media and other outreach efforts. D, they've specifically said they'll allow us to share contact information to update their records. And then lastly, they've said they're open, but there's a lot of confusion about how we can best help. So Patrick, if you'd launch that, thank you.
Interesting answers so far. Keep them coming, guys.
I guess I should have included they've not responded. I imagine some of you've had that response. Or perhaps if you're a state agency, it's gone the other way and you've reached out and not received responses.
Okay.
All right. So 3 of you have got a state agency that's open to participating. A number of you have heard that they'd like specific help with actual information. And then more of you have found that while they're open, they're not quite sure how you can best help. I hope that today will bring some clarity to some options, and then let's keep working together to find the best ways. It really is an all hands on deck moment in time. So I think one of the things we've seen from CMS's guides, from other guides that have been put out, is the earlier we engage enrollees, the better experience we're going to have. And we certainly see that across all healthcare. In every aspect of a patient's care, the earlier we engage with them, whether it's about their cost or the appropriate steps or their partnership in their own health, the sooner we engage them, the better results we see across all research and case studies. So to that end, California has really done a pretty good job, or at least they're moving forward more quickly perhaps than some. In December of 21, they mailed out to 14.4 million beneficiaries just as a test. Did they have the right contact information? So they could begin to whittle down, so they could begin to get the right information. To do even more than just that baseline reach out, which I still think is wonderful, they also have funded more fully navigators to assist enrollees in walking through the process. So some really positive things here. One of the things that CMS, that some others have talked about, is the possibility of using third-party data enhancers. So obviously every state Medicaid agency has some sort of database, some sort of listing of all of the enrollees and how to best reach them. As an MCO, you have that as well. And then we have a lot of external data sources. I think what some have not become aware of is that those external data sources, both regulated and unregulated, have appropriate use in the healthcare space. And we can take advantage of these in helping with this conundrum we're facing during the unwinding. So State Health and Value Strategies, which is a grantee from the Robert Wood Johnson's Foundation Institute, put forth this guide. They talk about the end of COVID-19 public health emergency, data and IT table stakes for retaining coverage gains. Strategy 1, adopt more effective and efficient use of data. Strategy 2, improve account transfer of data quality. And table stakes 3, expand capacities and capabilities of online portals. One of the things that I talked to healthcare providers about a great deal during the pandemic was that disruption can be a blessing. Disruption helps us look at how we do things and identify where our weaknesses are. And I think what we've certainly seen is we've got some weaknesses around enrollee data. And yet there are wonderful gains out there in the marketplace at large. So how can we take an advantage of this disruption to make advances that really benefit enrollees and patients in the future? So through this document, they identified a number of sources of data. They talked about the Lifeline program. They talked about the immunization database, health information exchanges, even the Department of Motor Vehicles or the Department of Labor, all great data sources. And they also mentioned third-party data enrichment sources. And they describe that data enrichment is a process of incorporating new updates and information into existing databases to improve their accuracy. They go on to say that third-party data enrichment could be considered to append missing or incomplete information for populations undergoing redetermination. You know, a piece of data that's striking to me is how much our vulnerable populations are still moving right along society when it comes to technology. The majority of these homes have a cell phone. The majority of these homes have internet connection. That all creates data. It creates contact data out there in the marketplace that could be leveraged to be sure we know where the patient is, where the enrollee is, and how to best get a hold of them. In fact, in the CMS guide, 10 best fundamental items to move forward with, number 7 was obtain updated contact information. And they talk about a number of ways to do that. It strikes me that they're missing the easiest, and that is to utilize a third-party data source to fill in the gaps, to take care of where you know you have a disconnect. So why should we continue to work in manual processes in difficult ways when there is an easy, affordable, streamlined approach available to us? So I'd love to hear your own opinion of third-party data resources. If it's something you've looked at, if it's something you utilize, or if it's something you just haven't heard much about. So our next poll question, in our own organization, our approach to third-party data assistance is: A, we currently utilize third-party data partners to enhance the demographic data of our enrollees. Maybe you go even further. We utilize third-party partners to better understand the financial and behavioral background of enrollees as it relates to their healthcare. Or maybe you've looked at this, but just chosen to not move forward. Or lastly, D, maybe you are not aware that there was an appropriate use case and regulatory data that you could use to contact your individuals. We'll give everybody just a couple minutes to chime in.
Don't forget to ask questions via the Q&A button, folks. You have the opportunity to do that. We encourage your participation. All right. Last chance. Going to go ahead and end the poll.
All right, so currently about 31% of you are using some sort of outsourced data to enhance your enrollee data. Almost 30% of you are even diving into deeper into your enrollees' behavior, maybe how to best communicate with them, maybe how they fulfill requirements that are shared with them from a medical provider, how their financial background interplays with their decisions. A few of you have looked but are not moving forward. And then almost equally to the ones, in fact, equally to the ones who are utilizing third data, a number of you were not aware that that was a possibility. So let's talk a little bit about what's possible. And this is not fully exhaustive of the resources out there, but just like the state values publication talked about, things like motor vehicle information, things like insurance information, things like credit header data for medical use. There's all kinds of sources around consumers of all things out in the marketplace. And there are appropriate places and time where that data can be leveraged, can be marshaled for healthcare purposes. One of the key areas is in this area of demographics that help with redetermination efforts. So when we talk about demographics, we're talking about name, date of birth, address, gender, social security number, kind of those phone numbers, emails. Interestingly, a number of data sources are able to provide you with a mobile number if you didn't already have one, with a correct email address if you didn't already have one. And if you're a state agency, you do have the ability to reach out to your enrollees without unique consent. Our MCOs, our partners, most of them have asked for consent in the enrollment process, in their interactions with their enrollees. And so they're able to utilize text as well. But that's only helpful if you've got the right mobile number. So there are solutions out there, demographic enhancement solutions that have been used broadly in healthcare for almost 20 years now. And really how this came about, and I think it'll make sense to you, is if I'm an emergency medicine provider, if I am an ambulance service, often my patients didn't know they were going anywhere with their healthcare today. They didn't bring their insurance card. They may not even be alert. They may not be able to give me their name. They may not be able to give me their address. And yet, post that encounter, I've got to have some way to get a hold of them. I've got to have a way to communicate with them. I've got to be able to obtain reimbursement, find out what their coverage is, if any. And so that began a process a little bit less than 20 years ago of finding a way to harness data to identify these patients and be able to communicate with them. So that's the obvious need. The other need is that often patients give us wrong information as part of their healthcare. They don't understand. They don't know how difficult a wrong address is for a healthcare provider or a payer, how it causes struggles in the denial process and the claims process. So over the years, these solutions have been refined and refined to where we are today. And that is that when we talk about a patient being seen for a healthcare encounter today, when we run the information that they gave at the time of the encounter through a demographic enhancement tool, over 60% of the encounters will be enhanced. What does that mean? It means we're going to replace information. It means it's an old address, a wrong date of birth, a wrong social, no phone number, we're going to provide one. And so think about the fact that that's a patient who was seen near term, probably no more than 15 days ago, often the very same day. And even with that interaction with a live patient, 60% of the demographic information is being improved. Imagine how much more these data sources can improve an 18-month-old contact file at a state agency. Because again, these third-party data sources like Zoll are going out to multiple data sources. They're aggregating that. They're coming back with the very best demographic information for that patient. So what's important if you're going to move forward and look at these things? Well, one, find someone that doesn't just tell you what's wrong, but they tell you how to replace it with what's right. Look for someone who gives you a confidence score around what they found. This is really important. It helps you consume the data. And then nationally, a benchmark would be around 55% improvement. And that is in the case of Today Healthcare Encounter. It likely will be higher among Medicaid enrollees. So here's just a brief case study for you. This is a sample of 12,500 encounters for a national emergency medicine staffing group. In that cohort, 59% of the encounters saw improvement in core demographic contact information. Now, what I don't want you to do, Missouri, unfortunately, had the experience. They partnered with LexisNexis. And LexisNexis found some other data. They found that there was a Juli Smith living in Florida that looked like it might be the same Juli Smith who was in Missouri. And Missouri acted on that information and they sent termination notices, unfortunately, to Missourians who had not moved at their original addresses and did not need to be terminated. Well, how can we avoid that as we partner with third-party data sources? The key is that confidence score. You want a score that tells you how many places did they find this new information? Did they find it just one place? Well, then maybe we want to put that in a notes field for a caller to work with. Did they find it in several places? Well, in that case, maybe we want to go ahead and overwrite and move forward with the data. If the data provider is highly confident this is the actual person and this is their new information. So that's a good tip to look for. As we look at these third-party sources, they help us deploy population-centric workflows. Well, what do I mean by that? What I mean is we can look at the Medicaid population. We can segment them into different cohorts based on the information we find around their behavioral economics, their identity, their family size, etc. So if I run some of these data sources and I find that a patient is of a certain socioeconomic level, then I might migrate them into some wonderful associations who help folks with the marketplace. Maybe I find out that the dependent child has aged out. I'm going to put them into one cohort. Alternatively, maybe I've looked at something like insurance detection, which we're about to talk about. I'm aware they have alternate coverage, so I can move forward with my redetermination process. So utilizing these data sources, I can really window down into buckets how to best work my population. In New Mexico, they've done some really exciting things. And part of it is understanding the patient and their financial background. So for example, they have asked their partners, their MCOs, to also work with the ACA health plans. And so they're helping in that transition. They also, their governor moved forward with $35 million to support those folks in the first few months of their premiums. So if we understand our population, there are a number of exciting things we can do and innovative things we can do to help them through this transition. And Mexico is just one example of a state trying to do things such as that. So if we wanted to move forward as a state agency or an MCO, how could I get that kind of information? Well, self-pay analyzer and healthcare propensity to pay tools that have been developed for many years now really can provide the information that I need to divide my population into cohorts. A self-pay analyzer and propensity to pay tool can be reversed utilized by payers and by state agencies. So what is the information it provides? Well, utilizing approved and regulated data for healthcare applications, it's going to verify that identity. We're going to make sure this really is Juli Smith before we provide any information. It will instantly, 4 to 5 seconds, share where a family, where an individual is on the federal poverty level. It'll provide an income estimate in real time based on current data, as well as an estimation of household size. So obviously that allows us to put this enrollee in this bucket and then work that workflow to confirm that detail with them, to partner them with the right partners within the cohort of the system, and to either re-enroll them or transition them to the best resource for their future needs. So here's a screen of what this looks like. This data can be returned in one of three ways. It can be worked individually, one at a time through a secure portal when someone is working alongside an enrollee. It can be done in batch format, where there is a export from the data source and an import into the data source. And it can also be done in API with platform applications. So this really can happen with your third-party partners in real time. And it allows you to look at things like this. We know that across the country, the median upper income eligibility level for children in Medicaid and CHIP nationally is about 255% of the federal poverty level. When families are above this, then they likely qualify for reduced cost sharing in the marketplace. So we can just utilize those eligibility criteria and associate it with the appropriate data state by state and put people into the buckets that help us to be intelligent about our workflow around redetermination. Alongside this, same kind of thing that's been in the industry for a long time, insurance detection or insurance discovery. This goes back to the number of times that patients arrive at a healthcare provider without their insurance information. Providers needed a way to easily obtain that information so that the patient didn't receive a bill they shouldn't have received, that there is a government or private payer. Here too, this can be utilized for coordination of benefits. This could be utilized to recognize what enrollees have had a change in economic event that means they're now insured elsewhere. And as of course, Medicaid is always to be the payer of last resort. So coordination of benefits is really important. We can do that easily through some automated resources, or we can do that in a more manual, difficult way where we're relying on the patient to give us the updated information and that enrollee to give us the updated information. Really good detection will share with us if someone is eligible, but maybe not yet enrolled in one of the programs. It can even look back after somebody has started redetermination. Again, we want to have a confidence score here that the data source provider is very confident in the coverage that they found, and they've even verified it. They verified it's active and in force, and they've given you actually some form, whether it's a screenshot of that information. And the very best tools will help you to know as a payer in other segments of your enterprise, coordination of benefits, where's primary, secondary, and tertiary. So these tools really can be helpful to MCOs, not just during the redetermination, but throughout the process. Particular individual, Medicare as well as a Healthcare One, this is obviously likely an Advantage plan. So in addition, can we go beyond the basics, the contact information, the federal poverty level, the insurance status? Could we utilize these data sources to really help us with the engagement with our enrollee? Well, this has been termed for a long time, patient engagement. Enrollee engagement is the exact same thing through the exact same kind of modalities. And there are wonderful providers. This goes along with CMS's fundamental guidance number 8 to launch effective communication strategies, including consumer outreach and revised notices. Well, I can be far more successful in that, whether I'm an agency or an MCO, if I really understand the individual. I understand how they like to communicate. I understand how they've communicated in a healthcare setting rather than simply a consumerism setting, because the behavior is different. Do they respond to a text? Do they respond to an email? Will they launch a link from a text to the platform that helps them walk through redetermination? Again, this behavioral data is out there, how these individuals engage with healthcare. Let's leverage that. This is just an example of how it's done on the provider side. But very easily, these things can be deployed on the enrollee engagement side. And I think of Illinois. Illinois has adopted a time-based approach rather than population approach. So in phase 1, they're going to be reaching out to everyone saying, please update your information. Phase 2, hey, change is coming. Enrollment starts here. We need your address. We need your information to re-enroll. And here's the timing. Phase 3, it's time to re-enroll. And then phase 4, after redetermination has been determined, transferring those people who are now ineligible to other appropriate insurance modalities. Well, in this entire process, this is only going to be effective if we really have wonderful communication tools, if we have engagement tools. The more we understand the individual and how they interact with these modalities, the greater our success is going to be. So if I'm a state like Illinois and I'm going with a time-based approach rather than a population-based, I want to really lean into engagement tools to maximize that. So we've talked about the pre-pandemic enrollment and how that might give us an indication of how the winding down will go. We've talked about how to engage our enrollees in an early way, and that the earlier we engage them, the better it will be. And we've talked about some tools for how we might leverage automation and third-party data sources in our efforts, how we might best partner together as MCOs and state agencies, as well as nonprofits who are coming to the table. So let's talk a little bit about forecasting the post-PHE future. I don't think any of us have a crystal ball, but I know a number of you have been playing with this for some time. So if you would, in the chat, rather than a poll question, this will actually be a free text question. If you would share with us, what do you estimate churn will be in your own organization as you've looked at this post-PHE? And then Patrick, if you wouldn't mind just sharing some of those that you see, if folks are brave enough to take a guess.
Sure. Come on, folks, be brave. We'd love to get your thoughts. Just type it in the chat window, and then we'll read them out.
All right, did we have any brave participants?
Not yet.
Okay.
We can jump to questions, and I can also remind our
Yeah, no worries.
attendees, our attendees, that if you have any questions, you still have time. We have a couple already, but we'd love more if you have them.
So again, as we kind of try to look forward, there have been a number of studies, folks who do financial analytics for a living in the healthcare space, who have really tried to nail this down. The numbers vacillate a little bit, but as we kind of pull it together in consensus, I think what we understand is that this really can be in the millions. Millions of people could lose their coverage if they're no longer eligible, or simply from facing administrative barriers during the re-enrollment process. One study really noted that folks who have English as their second language are truly going to be struggling in this way. As states resume redetermination, it's likely that there could be significant enrollment churn, and I think we all are anticipating that there will be. That some folks, especially in the pediatric population, will likely lose eligibility for a time and then re-enroll. That is a trend that we saw previous to the pandemic, and so we certainly think it will continue post-pandemic. While the Kaiser Family Foundation was not able to estimate what coverage options most individuals who are no longer eligible will migrate to, they do really consider the subsidized ACA marketplace, as well as folks who are now on employer-sponsored insurance. However, I think it's important to note that simply because someone has a subsidy does not mean that it's affordable. And just like we've talked about data sources here and how they can be of assistance, I think there's been some wonderful work done on the provider side in the affordability of healthcare and how to present options to enrollees and patients in a way that they can afford it. For example, often we'll see in healthcare that a patient will look at a $500 deductible and say, I cannot afford that. But if they're offered a payment plan of 6 weeks at a lower dollar amount, they go, oh, I can take care of that. Or if they're offered a discount that brings it to their level, they engage more fully. And I think we really should be looking again as we talk about this disruption, how can we help people transition more fully and appropriately when they are no longer eligible for Medicaid? Are there some things we can do around the way we present premiums to this population that helps them move forward in affordability and actually enrolling in alternate sources of healthcare insurance? Another statistic that we see as we move forward, while state Medicaid directors expect enrollment to decline substantially at the end of the PHE, they also expect expenditures to increase significantly. And if eligible individuals are not able to retain Medicaid or transition to other coverage, many could fully become uninsured. So what do the estimates look like? They vary greatly between 5.3 million to 14.2 million across the data sources. Interestingly enough, I imagine some of you were part of a webinar earlier today by CMS that actually projected 20 million. I think that is high. I don't know if you agree with that or not. But again, I think we can apply some of the pre-pandemic behaviors to understand of the non-continuous enrollment growth, what might we see, as well as by looking at some of the propensity to pay data, we can better estimate who might be able to transition to things like the ACA marketplace. And then what is the impact going to be on state budgets? And I think that helps us partner with our state partners is understanding this. Well, during the pandemic, they did all right. In fact, the estimates show that they received approximately 100.4 billion in fiscal relief, and that was nearly double what their actual expenditures were. So during the pandemic, state agencies have weathered the storm fairly well. But a new storm is coming, and while we see the enrollment diminishing as folks who are no longer eligible come off the rolls, we see expenditures increasing. And most states will see an increase in actual expenditures, and that really comes from increased utilization, increased provider reimbursement, and the fact that redetermination is going to be a process. So for much of 2023, they are likely to carry higher rolls and not have the full benefit of the FMAP. So Kaiser Family Foundation estimated the following. They are estimating a decrease of 5% in enrollment, an increase in total spending, and a significant increase in state spending of 14%. Something I think that's really key as we look at this, Daniel Tacey, who oversees Medicaid at the HHS Centers for Medicaid and Medicare Services, says we intend to and are using all levers available to us to make sure we are connecting people with coverage. And I think really a lot of those levers are all of us within the healthcare space. How can we partner together? I don't know about you, but when I look at a picture like this, I'd rather be the gentleman who took the time to soften the edges on the box and is now rolling a ball, rather than the ones who are still trying to push a square piece of concrete uphill. And in many ways, this disruption gives us the opportunity to shave off the edges that are associated with our state Medicaid systems, to look at how we can improve how we house our enrollees' data, how we interact with that data, how we update that data, how we interact with enrollees at large. Can we utilize the third-party solutions that are out there today rather than reinventing the wheel, partner with partners who can quickly bring to bear resources that have been tried and true in other segments of healthcare and can really help us walk through this redetermination process together. So I hope this has been helpful. Where you have ideas that maybe we haven't discussed, we'd be happy to talk about, and I welcome any of your questions.
Okay. We have a couple right now, but let's also give a final reminder. We do have time for more questions. So pop into that Q&A button. Any questions you can ask anonymously if you so choose. We'd love to have your involvement. And again, happy to answer questions. I'm sure offline, Julie, she mentioned, does not
Yeah.
mind getting in touch with you as well. You'll have her contact
Yeah,
information.
and here's my contact information, so please feel free.
Perfect. Okay. So our first question, pre-PHE, is there a nationally monthly average percentage or number of eligible individuals who are disenrolled for administrative or procedural reasons?
Yeah, so I couldn't find a specific number. The best work was done by Georgetown when they looked at the pediatric population, and what they found makes a lot of sense. So they found that 44% of those who were disenrolled re-enrolled inside of 12 months. What that tells us is that's likely, it's not absolute, but it's likely procedural reasons or simply an enrollee dropping the ball that kept them from staying on continuous enrollment. And if you think about it, in our pediatric population, a parent might let that lag, and then new school year, needing vaccines, go into my provider and find out that I did let it lag. So there are all kinds of reasons, but the best information was in the pediatric population. And what they reported was that they had seen 44% of disenrollees re-enroll within 1 year. And that's likely procedural issues.
Okay, excellent. You're welcome, Lorelei. Happy to answer. Let's see here. And then our final question, and there is more time if anyone does have any questions. Are there any best practices to get updated contact information on enrollees who speak English as a second language?
Yeah, absolutely. So one, when I utilize a third-party data source, language is no longer a barrier because you're actually not engaging the enrollee, you're engaging the aggregated data surrounding that enrollee. So that does remove the barrier of language. Additionally, a number of the tools and platforms that have been built for patient engagement do work within a varied number of languages. I've seen some with as many as 96 languages embedded in the platform tool. So that's another thing. When I look at an engagement tool, if I'm going to go to a partner, I want to go to a partner who does have languages loaded that are really important to my geographic region.
Okay, perfect. All right. Well, folks, those are our questions. Julie, any other closing remarks or thoughts before we close things out?
Yeah, we just absolutely shared that as a partner to MHPA, we are happy to brainstorm alongside you. We certainly would not say that we are experts at the struggles you are facing, but we are experts at understanding the data that is out there and how it can be aggregated in a way that could be helpful to you. And so we're happy to brainstorm. We're happy to run trials of your data to see if something works or if it doesn't work. It really is important to Zoll as a whole that our population stays insured. The bulk of our work is in emergent situations. Our medical device size creates ventilators, defibrillators, cardiac monitors, et cetera. And so we've been in this life-saving work since the inception of our organization. And as we launched the data side, we launched our data applications to come alongside healthcare so that those innovations could be even better and so that patients could access the care that they need. We work alongside the same vulnerable population that you do each and every day. And wherever we can bring resources to bear to help you, we'd like to do that. Please don't hesitate to reach out and brainstorm with us about what might be possible.
Okay, perfect. And again, Julie, thank you so much for this presentation. You had a lot of great take-home knowledge. And yeah, the PHE is obviously a hot topic and for good reason. And you were very helpful today. So I want to thank you for that. And I also want to reiterate, Zoll has been a great partner to MHPA and our member MCOs. So we appreciate the good work they do with our members as well. So with that said, I'm going to thank everyone for attending and registering. You will receive the slides from Julie and Zoll. You have our contact information right there if you need questions. Register for our next webinar Wednesday, which will be in 1 week from today. We'll be talking about texting the latest and greatest, and getting more information and engagement from your enrollees. So please join us for that. With that, I want to thank everyone once again and have a great afternoon.
Thank you.
Bye-bye.